So we're going to go ahead and get started. So welcome again, everyone, to our fifth and final day of the Critical Care Bootcamp, at least for this period of time. We appreciate you being here, and we are very excited to bring together a multidisciplinary group of individuals to help cover these topics of stroke, traumatic brain injury, diabetic ketoacidosis, sepsis, and now finally acute coronary syndrome. Um, we had the privilege of some of our colleagues from the University of Rwanda, as well as University of Nairobi in Kenya. We have several different specialties, including anesthesia, surgery, emergency medicine, and critical care, all involved in this effort. So thank you again for joining us. We very much appreciate it. Just some brief housekeeping and etiquette. We want to make sure things are maintained throughout the series and the webinar today. And so first and foremost is respect. Please kindly rescind if you disagree with something, and then please keep WhatsApp professional and relevant. And we'll go over the WhatsApp group in a couple of slides and how you can gain access, because I know that's been a very big question for everybody. This is also a huge community and a community that we cherish and love the collaboration. We, for this webinar, will use the chat function. Please continue to introduce yourself and let us know where you're coming from, because it's very exciting for us to see where you are globally. But we ask that you reserve your questions to the Q&A session of Zoom for the time frame of the webinar. And then last and foremost, the session is being recorded. So by this session, your attendance is your consent to being recorded. So just so that way you are aware, and thank you for that. Certificates, I know there's been a lot of questions revolving around our certificates, which I understand are very important, and we want to make sure everyone gets them. But for the certificates, you need to at least attend for a cumulative 45 minutes. They will be sent to the email address that you have provided upon registration for the webinar, and they should arrive within 7 to 10 days after the conclusion of the webinar. So just remember 7 to 10 days. Unfortunately, certificates are not available for independent online study, so you must have taken place 45 minutes for each webinar to receive credit for that webinar. All of the material that we cover throughout this entire week and today will be posted to the LRC, the Learning Resource Center, and there is the link below, and we can also place it in the chat for you all. The recordings of each lecture will be posted there shortly thereafter, if hopefully within the day, if not the following day of the webinar conclusion, as well as asynchronous material for you all to gain access and to be able to use that for later dates and to continue refreshing your knowledge. And if you need access and you don't have the link, the Q&R code on the side is also how you can access it. We do take into consideration our participants for whom English is not their first language. And so if you would like to turn on your closed captioning, it is available in English, and it's at the bottom of your screen at the under the show captions area. So please, if you need, take a moment right now and turn those on for yourself. And here is the QR code to gain access to the WhatsApp group that you all have been asking many questions about. We fully understand that we have reached capacity within the WhatsApp group, and we are working to mitigate this and potentially move to a different platform, but we will let you know as soon as we find a solution to the high demand. So thank you again for having such enthusiasm. We apologize if you haven't been able to access it due to participation maximum capacity. And lastly, I want to take this time to introduce our topic and wonderful speakers for today. So today we'll be covering our last, but certainly not least topic that you all have asked for, of acute coronary syndrome. The topic for today will be presented by our lovely team, Dr. Hazo Oginga. He is an anesthesiologist from the University of Nairobi. We also have Dr. Kimberly Liu, who is an anesthesiology resident from Stanford University. And we have Danielle Devakis. She is one of our wonderful nurse practitioners who we're very fortunate to have as part of the team, who has a subspecialty in critical care medicine at Stanford University. And then myself, Andrea Comiskey, I am an emergency medicine and critical care medicine physician at Stanford University as well. And without further ado, we will get things started.
Thank you, Dr. Andrea, for that wonderful introduction. So myself today, Dr. Hazo Oginga, and my colleague, Dr. Kimberly Liu, will be taking you through today's session. We're going to cover acute coronary syndrome as the last topic of this critical care bootcamp. I hope you've been having a quite educative and enjoyable session. We hope to keep up. So this is the outline of today's presentation. We'll go through the learning objectives, go through the differentials for chest pain. As we shall see, acute coronary syndrome can have quite the classical and sometimes not so classical chest pain. We go through the epidemiology and risk factors, the diagnosis and pathophysiology. We also cover the management as well as the complications of acute coronary syndrome. So this will be the learning objectives for today. So we'll create a differential diagnosis for chest pain. It will be varied based on whichever organ systems. Then we'll compare the different types of acute coronary syndrome, ranging all the way from stable angina to some instances where the patient might have sudden cardiac death. We'll identify the risk factors and symptoms of patients with acute coronary syndrome. We'll then understand the initial stabilization and management of patients with acute coronary syndrome. And finally, we'll recognize the complications of acute coronary syndrome. So starting off with the case for today, we have a 68-year-old gentleman, Mr. Cho, who has a past medical history of high blood pressure and type 2 diabetes mellitus with a positive history of alcohol use. And patient also reports compliance to losartan and metformin. So comes in with a chief complaint of a 6-hour gradual onset of chest discomfort, with associated sweating and palpitations. So we'd like you to keep this at the back of your mind as we go through the presentation. So at this point, I'll just give you a few seconds to write on the chat maybe a bit of the differentials we have for chest pain.
The question reads, list 3 differential diagnoses for chest pain.
And for each poll today, we'll give you approximately a minute, 30 seconds to answer.
You can also put your answer in the chat.
I'm seeing a lot of dyspepsia, GERD, MI, angina, PEs, MI, as I just mentioned, myocarditis, all great differentials.
So when a patient comes in with chest pain, initially it's not usually the classical symptoms you get to the patient with acute coronary syndrome. So you need to differentiate them based on the classical presentation the patient has. So you actually need to localize down on the presentation. So you have to know the onset, you have to know the exact location, so that you can able to narrow down on the exact differential diagnosis. Because patient coming in with chest pain can range, with some patients having very mild pain secondary to things such as costochondritis, which may not be very urgent, and ranging all the way to things such as acute coronary syndrome, which might require quite urgent intervention, as well as things such as maybe a patient with a perforated peptic ulcer, as well as patients with aortic dissection. So it ranges quite variedly. So when you're taking your history, you need to actually take quite a good history and localize the chest pain so that you can able to come up with the diagnosis to aid in management of your patient. As you can see from the pictogram, it ranges to several organ systems as well as the radiation. So you need to actually narrow down to what exactly is causing the chest pain for you to come up with a good diagnosis to aid in proper management of whichever patient presents to you. So we'll narrow down on the chest pain, which patients typically with acute coronary syndrome might present with. So typically, sometimes it's not, they may not describe it as pain. A patient might come to you, tell you they're having some sort of pressure in the chest. They might come in clutching the left side of their chest, just where around the apex usually is. They might complain of a squeezing sensation in the chest. And it usually varies according to whichever subject of patients you're looking at. So sometimes women might come with totally different symptoms. They usually tend to have a bit of a delay before they present with these symptoms. They also tend to have higher prevalences of hypertension and a higher risk of bleeding. So this is also quite different in elderly patients, for example. They might come with totally different symptoms as opposed to actually having a chest pain. So this particular subset of patients might come to you and complain of things such as confusion. They might come in a delirious state. They might actually be having a sensation of fainting or syncope, and they might be weak. So we need to narrow down actually to know what exactly the patient is presenting with. So this typical pain, you also need to know the onset. So typically for acute coronary syndrome, it's usually not a sudden pain, it's usually gradual in onset. And the patient might tell you, you might also need to classify what actually exacerbates this pain. Sometimes the pain might come in with activity, it might be worsened by activity, it might be pain that is actually present at rest. So you need to actually know, because this will influence your, to help inform you know what the severity of the pain is, or severity of the symptoms, or to help narrow down for you to know what exactly you're dealing with. So this pain sometimes might also radiate to the neck, to the jaw, to the arms, to the back, or the belly. So whenever you're taking history from these patients, you need to keep this at the back of your mind. So how it presents might actually make you have a high index of suspicion and narrow it down to a patient with acute coronary syndrome.
And I just want to add another piece to that, and that was a great overview of no one is textbook, and specifically female patients will present very atypically, and so you have to take that into consideration. Something as simple as upper abdominal pain, nausea, vomiting could very well be a myocardial event or a cardiac event with a female. I've had patients where their heart attack presented as simply as they just had shortness of breath. And so making sure to keep this on your differential is something that's super important because it can cause such a high rate of morbidity and mortality.
So next, we will talk about the risk factors for acute coronary syndrome, and these can be divided into those that are modifiable and non-modifiable. The modifiable ones include smoking, obesity, diet, and sedentary lifestyle, hyperlipidemia, hypertension, and diabetes. Non-modifiable risk factors would be older age, male gender, a family history, and ethnicity. These likely look familiar to those of you who attended some of our earlier webinars, like the stroke webinar on Monday, as there are many overlaps. Regarding ethnicity in the United States, Black and Hispanic patients are more likely to develop ACS, while Asian patients overall have a lower rate of ACS. There are some subgroups, such as Indian and Filipino patients, who are at higher risk than white patients. Other lesser known risk factors that I wanted to include would be patients living with HIV, and those who have received mediastinal radiation, such as for Hodgkin lymphoma or breast cancer. Being in a chronic state of inflammation contributes to the development of ACS. There are atherosclerotic cardiovascular disease, or ASCVD, risk calculators that can be used to determine if a patient should be started on primary prevention methods, including lifestyle modifications, a statin to lower cholesterol, or possibly aspirin. The QR code that you see in the corner is for one of these calculators made by the American Heart Association, called the Predicting Risk of Cardiovascular Disease Events, or PREVENT calculator. This specific calculator factors into consideration age, cholesterol levels, and blood pressure, whether the patient is on medications for cholesterol or blood pressure, their BMI, kidney function, diabetes, and smoking status. Also, I want to mention that patients with coronary artery disease are at the greatest risk of having a cardiac event, such as ACS, within 10 years. However, some conditions can be considered a coronary artery disease equivalent, and that would be patients who then have a similar risk of ACS, even if they do not have known coronary artery disease. These equivalents are diabetes, peripheral artery disease, and abdominal aortic aneurysm, and carotid artery disease. So even if they don't have known coronary artery disease, they may need some of the same prevention methods as other patients. So next, we'll talk about epidemiology, specifically from a global health perspective. Ischemic heart disease and subsequent acute coronary syndrome are the leading cause of death around the world, with 7 million deaths per year. Half of these deaths occur in low and middle income countries. We aren't going to talk about the specific details of the prevalence or incidence of acute coronary syndrome in every country, but just want to emphasize that death occurs from ischemic heart disease and acute coronary syndrome at younger ages in low and middle income countries compared to high income countries. The burden of ACS is also growing significantly in low and middle income countries compared to high income countries. Ischemic heart disease is one of the top 5 causes of death in all regions of the world except sub-Saharan Africa. And in sub-Saharan Africa, it is still the leading cause of death for patients who are over 30. This is in part due to a rise of obesity, hypertension, hyperlipidemia, smoking, and the consumption of alcohol, sugary beverages, and processed food. There's also a lower level of physical activity, and these can all be attributed to urbanization in these countries. Like we discussed in the previous slide, those are all risk factors for ACS. What's happening is that in part, there is an epidemiological transition as a country urbanizes, where life expectancy increases overall due to a decrease in infection, malnutrition, and maternal and child mortality. Therefore, there's an increased cause of death from non-communicable diseases such as ischemic heart disease and cancer. This graph highlights the difference in age distribution at the time of death from ischemic heart disease. The top bar graph shows men and the bottom is women. Blue represents low middle income countries, while red represents high income countries. As you can see, more patients are dying from ischemic heart disease in low and middle income countries from age 20 to 70 for men, and from age 20 to 79 from women. Death in high income countries primarily occurs in patients who are in their 70s and 80s. Because patients in low and middle income countries are affected at a younger age, in addition to a higher mortality rate at that age, there's also a significant economic impact due to loss of productivity at a societal level, causing an impact of 129 million disability adjusted life years worldwide per year. Now we will just dive into the different conditions that fall under the umbrella of acute coronary syndrome, as well as stable angina, which is related, but it's not considered ACS. So at rest, the heart already maximizes how much oxygen it's extracting from the blood. When more oxygen is needed, such as with exercise, the heart must increase coronary blood flow to get more oxygen. And this is done by decreasing the coronary vascular resistance. Ischemia occurs when there's a reduced blood flow to the myocardium that does not meet demand. And then infarction occurs when there is a total loss of blood flow to a given artery. And this can result in necrosis and cell death. So in stable angina, there's a stable atherosclerotic plaque in the coronary artery that reduces blood flow. Patients may not feel this at rest, but when their heart needs more oxygen during exertion, the vessel is not able to dilate enough to meet this increased demand, and the patient then gets anginal pain. There is demand ischemia, but no infarction. Therefore, the ECG looks normal, and so do cardiac biomarkers such as troponin. Patients often will feel better by resting or taking sublingual nitroglycerin. In unstable angina, the plaque ruptures and is no longer stable. It develops a thrombus around the plaque, which causes a partial occlusion of the vessel. Now patients will have angina pain both with exertion and at rest, and that pain usually progresses pretty quickly. The ECG may look normal, or there may be inverted T waves or ST depression. Again, there is not a full infarction, but there is ischemia. The main difference between unstable angina and a non-ST elevation myocardial infarction, which exists along a spectrum, is the troponin levels, which will be elevated with NSTEMIs. This is because there is a degree of subendocardial infarct that's causing myocardial tissue damage and the release of troponin into the bloodstream. The subendocardial myocardium, which you can see in the picture, is like the inner part of the myocardium, is impacted because that's the tissue that's farthest away from the coronary arteries, which are on the epicardium or the outside of the heart. Finally, an ST elevation myocardial infarction is a complete occlusion of the lumen of the coronary vessel, causing a total lack of blood flow and transmural infarction across the entire myocardium. The ECG will show a signature hyperacute T wave or ST elevation, and troponin levels will be elevated. There are specific criteria for diagnosing a STEMI on ECG, including ST segment elevations greater than or equal to 1 millimeter across 2 anatomically contiguous leads, or ST segment elevations greater than or equal to 2 millimeters for men, or 1.5 millimeters for women in leads V2 and V3. A new left bundle branch block in the setting of ACS symptoms is also diagnostic for a STEMI. And we will talk a little bit more about ECG interpretation shortly.
So now this is a diagram here depicting the heart. So what we're going to go through here is we're going to just have a rough overview of the blood supply to the heart. So just looking at what Dr. Kimberly has gone through, I'd like you to remember that these coronary arteries are usually their end arteries. So if there's any ischemia or any thrombus, anything that interferes with blood supply to any section of the downstream myocardium, that's why you end up with infarct or cell death of whichever section of the heart that is affected. So the muscle is usually generally divided into three broadly, as you know, the endocardium, the myocardium, and the epicardium. So the endocardium in itself will get nourishment as blood flows through all the three chambers, all the four chambers of the heart. Sorry. But you remember the rest of the myocardium in itself is usually quite thick. So there's usually not enough or sufficient time for oxygen to diffuse across during the circulation to the heart. So majority of it will get its blood supply from the coronary arteries, which are broadly divided into the left and the right coronary artery, which basically they originate from the aortic root. So the left coronary artery usually comes down through the intraventricular groove, goes through the intraventricular septum. So majorly it supplies its blood to, it divides into two, the left coronary divides into the left anterior descending, as you can see, the circumflex artery on this other side. So the left anterior descending is the one that majorly supplies blood to the intraventricular septum, the apex of the left ventricle, as well as the anterolateral myocardium. So this is important for us to know whichever section of the artery is affected. As you shall see, it will be representative in your ECG findings. So apart from the left anterior descending, it also gives off a circumflex branch, which mostly supplies the posterior wall of the left ventricle, as well as the SA node in like around 40% of patients. Then on this other side, we'll have the right coronary artery, which also gives a sinoatrial branch, which supplies around 60% of the SA node in 60% of patients. It also gives off right marginal artery, as well as the posterior descending artery, which is responsible for supplying a majority of the right ventricle, as well as the posterior portion of the intraventricular septum. So these arteries will majorly inform your management, as well as your interventions, depending on how many vessels are involved, whether you'll go ahead and do a PCI or probably do a coronary artery bypass graft, as we shall see later.
So during ACS, the affected coronary artery can be identified using ECG, like what Hazel was talking about on the earlier slide. ECG changes in leads V1 to V6 usually involve the LAD, while leads 1 and AVL affect the circumflex artery. The infected artery for an inferior MI is leads 2, 3, and AVF, depends on the patient's coronary arterial dominance. So similar to what Hazel was saying, for most patients, the right coronary artery supplies the posterior descending artery, which supplies the inferior portion of the heart. The left circumflex artery supplies the PDA for a minority of patients. Unfortunately, we don't have the time today to go in depth about interpreting ECGs, but we did provide a few resources that you can find through these QR codes that will take you through the basics of ECG interpretation.
We'll go back to our patient, Mr. Cho. So on physical examination, on general examination, Mr. Cho is alert. He's in a bit of acute respiratory distress and is quite dyspneic. So vital signs, we find his blood pressure is 102/60 millimeters of mercury. He's a bit tachycardic with a heart rate of 113 beats per minute. He's also tachypneic with a respiratory of 26 breaths per minute. Saturating at 88% on room air with a temperature of 36.7 degrees Celsius. So you do an ECG, and this is what you find from the ECG. So at this stage, we'll also give you a few minutes just to look at the ECG and give us your probable diagnosis. So what is the diagnosis? A, it would be an inferior STEMI, B, it would be an N STEMI, C, it would be pericarditis, D, it would be an anterolateral STEMI, and E, it would be costochondritis.
I'm getting a lot of answers for B.
So from the poll, seem to be getting quite varied answers for this, but majority of you have chosen an anterolateral STEMI. Other people have chosen an N STEMI, and the rest have chosen an inferior STEMI. There are a few chosen pericarditis. So for this particular ECG, I know it's a bit challenging from this sort of presentation to actually go through ECG in detail. But from this, whatever was actually quite evident was mostly the ST elevation was mostly in your anterior leads and a bit of your septal leads. So it's quite obvious here in your V1 and your V2, and also a bit in your V3 and your V4. So I'm thinking whatever maybe the rest of us could be saying in the inferior leads, which include your lead 2, lead 3, and also your AVF, would be some sort of reciprocal changes, which could also confirm with the other leads, V7, V8, and V9. But majorly this would be an anterolateral ST elevation myocardial infarction. So the correct answer here would be D.
Now we will go into the one of the most critical portions of this webinar, which is the immediate management of patients with suspected or confirmed ACS. This is one of the algorithms that we'll be using, and you can access it using the QR code in the corner. As with all critically ill patients, the clinician should first and foremost establish the patient's ABCs, airway, breathing, and circulation. Monitors should be applied to assess blood pressure, telemetry, or continuous ECG, and pulse oximetry. Patients should only receive supplemental oxygen if their SpO2 is less than 90%. The patient should get an IV for medication and or fluid administration when it's appropriate. And the patient should then receive aspirin as soon as possible, even before they arrive to the hospital. Aspirin can be given both orally, where it's chewed and swallowed, or rectally. The dose ranges from 162 milligrams to 325 milligrams. The clinician should also obtain a 12-lead ECG and lab work, including cardiac biomarkers like troponin, a complete blood count, a complete metabolic count, and then coagulation studies. They should take a focused history and physical to help narrow the differential if it's not clear, and evaluate for possible contraindications for anticoagulation or fibrinolysis. If the patient is having ongoing chest pain, they can take sublingual nitroglycerin tablets at 0.4 milligrams or a spray. every 5 minutes for 3 doses. IV nitroglycerin can be an option as well. Morphine is usually the pain medication of choice for patients who have chest pain that does not resolve with nitroglycerin alone. If it is available, the cardiac catheterization lab should be activated for possible intervention. The goal is to do all of these steps at the same time so that they are completed within 10 minutes of seeing the patient. Since we mentioned nitroglycerin, I wanted to include the contraindications because it can cause a decreased preload to the heart and hypotension. These contraindications are severe aortic stenosis, hypertrophic cardiomyopathy, a suspected RV, MI, hypotension, significant bradycardia or tachycardia, or recent use of a phosphodiesterase 5 inhibitor such as sildenafil. It's also important to note that the initial ECG is often not diagnostic because it's a dynamic condition that changes quickly. If the suspicion for ACS is high based off of the clinical picture, the ECG should be repeated, usually around every 15 minutes. So this particular algorithm you see here splits into 2 pathways. One is a concurrent assessment where the patient is still being evaluated for possible ACS and other diagnoses have not been ruled out yet, and that is on the left. And the other is immediate ED and cath lab treatment, where we know the patient already has a confirmed diagnosis of ACS, possibly from urgent care or another hospital, and they're coming into the cath lab or ED for definitive treatment. I just want to say that these steps that you see on the right and the left are not mutually exclusive. Usually patients will receive all of these tests and interventions. So this is the second half of that same algorithm, and it divides based off of primarily the ECG interpretation. So if the ECG indicates a STEMI, then reperfusion is the primary goal. You can see this on the left side. Reperfusion should not be delayed. If the time from symptom onset is less than or equal to 12 hours, the patient should go to cath lab for percutaneous coronary intervention, or PCI, within 90 minutes of first medical contact. If the patient cannot get to PCI within 120 minutes, then the patient should receive fibrinolysis instead, and that should happen within 30 minutes. Between these two options, PCI is strongly preferred because it has shown to be more efficacious than fibrinolysis, especially for patients with signs of cardiogenic shock, heart failure, patients who have a late presentation, or contraindications to fibrinolysis, which we will talk about. If it has been more than 12 hours since symptoms started, fibrinolysis is no longer indicated, but the patient still could go to PCI, especially if there is evidence of ongoing ischemia or a high risk of death. Patients with a STEMI should also receive anticoagulation, antiplatelet therapy on top of aspirin, and a beta blocker unless it is contraindicated. If the ECG shows unstable angina or an NSTEMI, the troponin level should be checked, and then if it's elevated, that helps to differentiate between these two conditions. For patients that have high-risk features, such as an ST depression, elevated biomarkers, refractory chest pain, hemodynamic instability, ventricular tachycardia, or signs of heart failure, you should consider proceeding to cath lab for intervention, even though it's not a STEMI. Patients who do not go to STEMI should be go to a cath lab should be admitted for close monitoring and medical management. And you can see here in these 2 QR codes on the slide, 2 risk stratification scores, the TIMI score and the GRACE risk score, which helps to determine which patients would benefit from early aggressive intervention. Medical management for ACS in all of these categories includes an antiplatelet therapy, which is aspirin, and a P2Y12 inhibitor, such as clopidogrel. It also includes anticoagulation, which is usually in the form of heparin or enoxaparin, ACE inhibitors or angiotensin receptor blockers, statins, and beta blockers. We will go into details about those shortly. Finally, as you can see on the right side, if the ECG is low risk for ACS and biomarkers are negative, the patient should be observed and receive serial ECGs and biomarkers, usually about every 2 to 6 hours. At this point, you should consider alternative diagnoses, like what we discussed in our differential earlier. Any dynamic ECG changes or positive biomarkers should lead to intervention for an NSTEMI, as we described. If the patient remains stable, you can consider a non-invasive diagnostic test, such as a stress test.
So we move on to the HART score, which is basically a way you can stratify your patients who come in with acute coronary syndrome, so that you can inform which patients you want to pay more attention to and which patients you can actually discharge home without any worries. So it's a sort of scoring system that's usually divided into 5 based on the mnemonic itself, with the H here being representative of the history. So as we'd gone through this earlier, whatever history you're able to elicit from the patient needs to be quite highly suspicious for acute coronary syndrome. We would give the patient a score of 2. They come in with all the classical symptoms and presentations of myocardial infarction. Then you give a score of 1 if it's moderately suspicious, and a score of 0 if it's slightly suspicious. And then based on your ECG findings, you also have 3 scores. When the ECG is normal, you give a score of 0. When there's non-specific repolarization disturbances, or you have maybe a left bundle branch block, you give a score of 1. When there's significant ST segment deviation, you give a score of 2. Based on the age of the patient, you also have 3 scores, with those less than 45 years being given a score of 1. Those between 45 to 65 years being given a score of 2. And those above 65 years being given a score of, those 45 to 65 being given a score of 1. Those above 65 years being given a score of 2. And then the risk factors, as you have seen, in our situation here, Mr. Cho is both diabetic and hypertensive. So you put also other risk factors into consideration. So your patient with more than 3 risk factors of history of any atherosclerotic disease, you give a score of 2. 1 or 2 risk factors, you give a score of 1. No risk factors, you give a score of 0. So based on your troponin levels, you also have 3 scoring systems. If it's more than 3 times the upper limit of normal, you give a score of 2. Between 1 to 3 times, you give a score of 1. And then if it's within normal, you give a score of 0. So based on this scoring system, as you can see on the figure on your right, just below the graph, so it's generally, the scoring system generally ranges. If a patient scores between 0 and 3, you can discharge the patient home. There's very little risk, around 1.9% risk of getting any major adverse cardiac events. Then between a score of 4 to 6, you can decide to observe the patient and do risk management. If the patient scores between 7 and 10, this is a patient who requires your attention and might require interventions with regards to maybe reperfusion therapy or something. So you need to initiate your management according to your protocols, as what you've seen for acute coronary syndrome. So moving on to medication management. So these are some of the additional medications you can give to these patients. So broadly, you can have your beta blockers, but beta blockers are not routinely administered to everyone. So they're only given to patients who present within the first 24 hours, unless there's a contraindication. So the contraindication here includes patients who already come into you and they're hypotensive, probably secondary to things such as cardiogenic shock. They might have bradycardia, or patients with severe reactive airway disease. So those are patients you don't want to give beta blockers to. You might end up worsening their state. So the preferable beta blockers you want to give these patients are usually your cardioselective beta blockers, including drugs such as metoprolol or atenolol. So you start usually with your metoprolol. You can give around 25 milligrams orally. And in some instances, if there's persistent chest pain, hypertension, or tachycardia. In the absence of heart failure, you might have to switch to IV beta blockers. So in this instance, you may still give your metoprolol, but the typical dose is usually you give 5 milligrams, and then you can repeat it up to around 3 times. So you keep giving, and then you keep monitoring how the patient responds to whatever drug you've administered. So the other drug you can give to this patient include your renin-angiotensin aldosterone inhibitors. So you can either choose to give your angiotensin converting enzyme inhibitors or your angiotensin receptor blockers. So they usually help prevent ventricular remodeling, and also they decrease the risk of subsequent heart failure in these patients with acute coronary syndrome. And then you can also administer your statins here. An example here being atorvastatin 80 milligrams or rosuvastatin 20 to 40 milligrams. So in some instances, you might find patients who might already be on statin therapy at the time of presentation. So you might actually have sometimes to up the dose depending on whatever dosage they came, whatever dose they've been on from home. So all patients with acute coronary syndrome actually require to be given statins regardless of their baseline LDL levels.
So aspirin, like we talked about, is perhaps the most important drug intervention that can be given in the setting of acute coronary syndrome, given that it's accessible and has a proven mortality benefit. We talked about the dose, which is 162 to 325 milligrams in either a chewable non-enteric formulation or a rectal suppository for patients who cannot take PO medications for whatever reason. And then you also want dual antiplatelet therapy by adding a P2Y12 inhibitor. And this is indicated for all ACS patients unless there is a contraindication, such as a high bleed risk. The nuances of what specific P2Y12 inhibitor to give is beyond the scope of this webinar, but clopidogrel is the most commonly used. Other options are ticagrelor and prasugrel. For anticoagulation, this is also indicated unless there's a contraindication. The most commonly used are unfractionated heparin and enoxaparin. Usually you decide based off of what's available at your facility, and they also what pathway the patient is going, whether they're receiving PCI, fibrinolysis, or no reperfusion therapy. The main differences between these two are that unfractionated heparin is an IV formulation that you can quickly titrate and turn off. And you can also reverse it with protamine. Enoxaparin is an injection and not as easily reversible. So we wanted to poll the group and see which of these antiplatelet agents are available in your healthcare setting and choose all that you have available. Awesome. Thank you for sharing. it's really helpful to think about what different medications are available in different healthcare settings. And for the most part, most patients do receive aspirin and clopidogrel, which is what we see in this bowl. Now we'll talk about PCI versus fibrinolysis, which we've alluded to many times already in this talk. PCI, again, stands for percutaneous coronary intervention, which is a minimally invasive procedure performed in a cardiac catheterization lab. Interventional cardiologists use balloon angioplasty to revascularize the occluded coronary artery, and then a stent is placed to maintain patency. And we'll talk more about those stents shortly. Fibrinolysis, also known as thrombolytic therapy, is a pharmacologic intervention. It uses agents such as tenecteplase, retiplase, alteplase, and streptokinase. These agents work by lysing acute blood clots, by activating plasminogen, which forms plasmin, and that is the protease enzyme that cleaves fibrin crosslinks in a thrombus. You may recognize these agents because they're the same ones that are used for acute ischemic stroke, which again we talked about on Monday. Fibrinolysis is most effective within the first 3 hours of symptom onset. After 12 hours, the risks of fibrinolysis outweigh the benefit. And we also wanted to quickly poll the audience again and ask if your healthcare setting has access to PCI.
From the chat, we're getting a lot of no's.
PCI is definitely an intervention that requires a lot of resources. You need the cath lab and you need staff that is available 24/7 to come in to do it, ideally within that 90-minute window for patients who have a STEMI. It has really dramatically changed management here in the US, but whenever it's not accessible, especially within 2 hours at the latest, fibrinolysis is the option. Great, thank you. So we've talked a lot about all these different interventions, whether it be a procedure or a medication, and I wanted to touch on whether there's been a mortality benefit shown through a study. Those that have a mortality benefit is aspirin and fibrinolytics. These were both shown through the ACS-2 trial that we talked about earlier. PCI, again, has dramatically changed outcomes for ACS anticoagulation, RAS inhibitors like ACE inhibitors in ARBs, the P2Y12 inhibitors such as clopidogrel, statins, and beta blockers. Those that have not shown a mortality benefit are morphine, oxygen, specifically for patients that are not hypoxemic, and nitrates. Regardless, all of these still play a role in the management of ACS. The ACS-2 trial showed that both, again, there's a mortality benefit for ACS, and aspirin in particular, I wanted to mention, decreases mortality by 23%. Supplemental oxygen for a non-hypoxemic patient hasn't necessarily been shown to be harmful, but it also hasn't been shown to be beneficial. And due to, there's always a risk of oxygen toxicity, it should be reserved for patients whose SpO2 is less than 90%, like we talked about. Morphine also has not shown that mortality benefit. It's primarily for patient comfort. and nitrates have not been shown a mortality benefit and can actually cause harm by, like we mentioned, for patients with a contraindication, it can cause hypotension and decreased preload, specifically in right ventricular MIs. So patients who have ongoing chest pain and no contraindications should get nitrates, but it should not be given universally.
So we'll go back to our case. So here, Mr. Cho receives sublingual nitroglycerin, aspirin, clopidogrel, rovastatin, metoprolol, and morphine. So while giving a history, it reveals that a month ago he had an episode for 30 minutes where he could not move his right side. He was supposed to start taking new medications for this condition, but has not received them from his pharmacy yet. So we'll do another poll again. So what would be the best intervention for Mr. Cho's STEMI? So would it be either we do a percutaneous coronary intervention or we do fibrinolysis? So just give you a few more minutes to answer this poll. So you have the answers to the poll back. So majority of you, 70% have chosen PCI. So this is going to inform the next part of our discussion. So based on contraindications to fibrinolysis. So in the case of Mr. Cho here, his history suggests that he previously had a transient ischemic attack. We've seen that a month ago he had a 30-minute episode where he could not move his right side, which ideally should be a relative contraindication for fibrinolysis. But now, based on the fact that in this instance, now PCI will be superior to fibrinolysis, I think it would be the best intervention of choice for him. So sometimes when you have relative contraindications for doing a procedure, it's usually good practice, usually to inform the patient and also to make a decision, to have a shared decision-making process and share with the patient the risk and benefit analysis. So for absolute contraindications, as we've seen, which include things here such as major trauma, surgery, head trauma within 3 weeks, things such as prior hemorrhagic stroke, ischemic stroke within the preceding 6 months. If you have a central nervous system neoplasm, whether it's a primary lesion or a metastatic one, if you have gastrointestinal bleeding within 1 month or any active bleeding. So if a patient has any of the above, then those are absolute contraindications for your PCI. So in those instances, we just give fibrinolysis, which would doing PCI would actually put the patient at more harm. So in those instances, just go ahead and do your fibrinolysis. So we'll cover a bit about intracoronary stents. So broadly, they usually divided into two. You have your drug-eluting stent and your bare metal stent. So the stents are basically what we put into the vessels, the coronary arteries, to keep them patent after doing your coronary angiography and your catheterization. So you leave the stent in to keep the arteries patent to continue supplying blood to the myocardium. So as you can see, how your drug-eluting and the bare metal stent work is actually divided is quite different. So the bare metal stents are majorly they're falling out of favor, and their use is actually decreasing because of the increased risk of restenosis and the improved revascularization. So the use has actually fallen out of favor. So they're being used for, actually they're still being used in patients who can't or won't be compliant to the dual antiplatelet therapy. So due to the risk of stent thrombosis, if a patient with, for example, a drug-eluting stent discontinues the dual antiplatelet therapy too early. So as you can see here, the mechanism is quite different. So for the drug-eluting stent, they have a coating that keeps producing drug basically to stop overgrowth of scar tissue, which might actually end up blocking a blood vessel. While your bare metal stents here, they usually just stainless steel with no additional coating. So the risk of blood clots leading to further stent thrombosis is usually higher with your drug-eluting stent, because ideally still the stent will be recognized by the body as a foreign tissue, which may then lead to this clot formation around the stent. While restenosis with bare metal stent actually occurs from tissue overgrowth. So with regards to the recommendations to continue a dual antiplatelet therapy for a patient who's on a drug-eluting stent, you'll have to take the drugs for a period of 3 months to 1 year. While a patient who has a bare metal stent might only have to take the drug for a period of 1 month. So this is why, for example, you might need the bare metal stent in patients who won't be able to comply with the dual antiplatelet therapy for a prolonged period of time.
I want to make another point too when it comes to the fibrinolytics, and then a lot of those contraindications can also be risk factors and contraindications to receiving PCI, because during the PCI procedure, they do have to undergo heparinization. So they receive large doses of heparin and then need to be put on the dual antiplatelet therapy afterwards. So if they're going to proceed with PCI or fibrinolytics, there's a lot of risk benefit discussions that happen with not only the patient, but also the providers. So the cardiologists, if they want to proceed forward with this intervention, given that if they are having an active GI bleed and you give them a large dose of heparin, it's only going to make the GI bleed worse. And so it's all about how to risk stratify them appropriately and make sure that you're not doing more harm to your patient, and figuring out the correct timeline to do each intervention.
So thank you. We won't go too in depth about comparing PCI to coronary artery bypass grafting or ACABG, but wanted to highlight that this can be a decision point for patients. And it often the decision involves the number of coronary vessels are involved, whether that's 1, 2, 3, or more. It also relates to the location of the stenoses, as more distal stenoses are less amenable for PCI. You could also always have a patient who first had a primary PCI for ACS and then later undergo ACABG. For patients that are admitted to the hospital for ACS, undergoing a CABG during their hospital stay is an option. In terms of in-hospital mortality rates, it's comparable if it's performed between days 1 to 7 post-ACS. On day 0 and after day 7, there's a higher mortality rate. Of course, one of these options is a minimally invasive procedure that you access usually through the groin or the wrist. The other is a major open heart surgery. And so PCI is significantly less invasive and has a shorter hospitalization. It's generally a good option for older patients. For younger patients with a longer life expectancy in general, the CABG can be preferred due to its protection against disease progression. now that we've talked so much about management and treatment, we just wanted to again highlight some differences in the management between high-income countries and low-middle-income countries. In general, patients, regardless in high-income countries or low-middle-income countries, receive aspirin and lipid-lowering therapies like statins over 90% of the time. Most patients also receive a beta blocker at 78% and 68% for ACE inhibitors. But then the use of heparin is a little bit lower, and then about 39% of patients with a STEMI receive fibrinolysis in low and middle income countries, according to this study.
So 24 hours after Mr. Cho undergoes the PCI for an anterior STEMI, he develops sudden severe shortness of breath and hypoxia. So he's urgently intubated, and we do a chest X-ray, which, as you can see on the right here, shows bilateral pulmonary edema. So we'll just do another quick poll again as what would be your probable differential for the possible complication that has occurred here post-PCI? So would it be A, hospital-acquired pneumonia, B, pulmonary embolism, C, severe mitral regurgitation, D, tension pneumothorax, and E, asthma exacerbation? So we'll give you a few minutes again to pull in your answers.
There was some request to go back to the X-ray, if you could, to help people inform their decision. We're getting a lot of answers of B in the chat.
So from the results of the poll, it seems like majority of you have chosen. So you've lost the poll results. So it seems like majority of you have chosen pulmonary embolism. The others have chosen with mitral regurgitation being the second most common choice, with hospital-acquired pneumonia and tension pneumothorax also being chosen. So this will inform the next part of our discussion. So keeping in mind that whatever case you're dealing with here, we had Mr. Cho who underwent PCI for an anterior MI. So the correct answer for this would be severe mitral regurgitation. So you can also not rule out an embolus completely, because we can see also sometimes that some of these patients, one of the other complications, usually you might end up with a ventricular thrombus, and it's not uncommon for you to have thromboembolic complication secondary to some of these things. So yeah, but the most common here would be mitral regurgitation. So based on that, so what test would you order? So we'll do a repeat poll again, another poll again, and see what test would you order. Would it be troponins? Would it be a pulmonary function test? Would it be blood cultures? Would it be a complete blood count? Or would it be a transthoracic echocardiogram?
We are getting a lot of ease in the chat. And Hazel, if you don't mind just speaking a little more loudly for our participants, I think they'd really appreciate it.
Noted. So from the results of the poll, majority of us have chosen a transthoracic echocardiogram, which I totally agree with the right test to request for once you're suspecting possible mitral regurgitation in this patient. So we'll move on to the possible complications of ST elevation myocardial infarction. So some of these complications might occur secondary to the disease process itself, or sometimes, as we've seen, might occur secondary to some of these interventions we as healthcare providers will put these patients through. So they're broadly divided, as you can see down there, into some of these electrical complications. You might see a patient coming in with arrhythmias here. It's not uncommon to find a patient with ventricular fibrillations or ventricular tachycardias. But one of the most common complications is usually bradycardias, especially if the ischemic event is affecting any of your right coronary arteries. So some of the other complications you can see here, your thromboembolic complications, as we've alluded to. It's not uncommon for you to have an embolus coming from the ventricle all the way to your carotid circulation and affecting whichever circulation, maybe your pulmonary circulation, the circulation to your brain. You can also get your pericardial complications as well as your ischemic complications and your mechanical complications. So my colleague will go into more depth about these complications.
So first, we'll start with mechanical complications. To provide more context for our poll questions and Mr. Chow, the hypoxia and severe dyspnea and severe bilateral pulmonary edema was alluding to him developing a papillary muscle rupture. This is where ischemia to the papillary muscle causes to burst, and then you get a severe mitral regurgitation. It most commonly is from occlusion of the right coronary artery, which affects the posteromedial papillary muscle, because that's only a singular blood supply. The anterolateral papillary muscle receives blood supply from both the LAD and the left circumflex, and is thus more protected from rupture and necrosis. The timing in terms of onset is within 7 days post-MI, with a median presentation time of about 13 hours. And then
Sorry to interrupt. We have about 10 minutes left.
Okay, got it. And then this results in severe mitral regurgitation and acute pulmonary edema. Like we talked about, management usually includes a chest X-ray, a TTE, or a transesophageal echo, which looks at the heart from behind in the esophagus for more clear pictures. Patients may need non-invasive or invasive ventilation to support them. And you can decrease the afterload to alleviate mitral regurgitation and enhance forward flow. These patients often will usually need early surgical intervention from a mitral valve replacement or repair. Other complications, and we won't go into too much detail, but ischemic mitral regurgitation is from ischemia causing annular dilation of the left ventricle or leaflet motion dysfunction, and usually also would need a mitral valve replacement or repair. You can have also rupture of various or aneurysms of various parts of the heart, such as the ventricular septum, which is usually from ischemia to the septum. from an anterior MI. You can have free wall rupture, which is more seen from transmural MIs and anterolateral MIs and patients with a later presentation or delayed thrombolysis. And then you can have true and pseudoaneurysms. In pseudoaneurysms, the ventricular wall ruptures, but it's confined, as you can see in this diagram, by the pericardium and fibrous tissue. In a true aneurysm, there's a non-contractile bulge coming from the ventricle that includes all layers of the myocardial wall. True aneurysms can be medically managed, but pseudoaneurysms can expand and rupture, and they need surgical repair. We'll also talk later about a cardiogenic shock and LV failure, which is a complication of MIs, and then RV MIs is usually due to blockage of the proximal RCA, and you can see hypotension. These patients are usually a little different from other MIs because they would usually benefit from some fluid boluses. And now briefly on electrical complications. This is primarily due to re-entry from electrical irregularities to the ischemic myocardium. It can also be from reperfusion syndrome, where after the artery is reperfused, ions such as potassium, lactate, and other metabolic substances enter the circulation from the ischemic area. These used to be a leading cause of death for STEMI patients prior to coronary care units. Like Hazel mentioned, for atrial tachyarrhythmias, this includes sinus tachycardia, atrial flutter, atrial fibrillation, and paroxysmal supraventricular tachycardia. It's usually associated with a poor prognosis and treated with beta blockers if the patient is stable. Ventricular tachycardias are associated with an increased mortality for those who have sustained VT, usually occurs after a transmural infarction or LV dysfunction. This, along with ventricular fibrillation, usually requires prompt cardioversion and defibrillation, as well as correcting underlying electrolyte imbalances. And finally, bradyarrhythmias are usually due to ischemic damage causing AV block and intraventricular block or damage to the bundle branches. And so you can get varying degrees of AV block. The management is just to be careful with beta blockers and calcium channel blockers, and then either temporary or permanent pacing. Other complications finally would be recurrent infarction causing ischemia, thromboembolic complications like Hazel mentioned from an LV thrombus, especially for patients who have an aneurysm, and then a variety of pericardial complications, including an effusion or early pericarditis, which is from inflammation of the pericardium from transmural necrosis, or later post-cardiac injury syndrome, which is from a hypersensitivity reaction to cardiac antigens released into the bloodstream. Hazel.
So for investigations there, as you've seen, you can do a transthoracic echo. So we won't go into so much detail about this. I think this would be beyond the scope of this lecture. But maybe just a small review of whichever views you can see whenever you're using a transthoracic echo. So you have your parasternal window, where you can do your long axis or your short axis view, your apical window, your subcostal window, and your suprasternal window. So we have a small code here which you can check later in our LRC, so you can go later and just have a further look at it when the interest of them.
And then now we'll touch very briefly on cardiogenic shock, which, like I mentioned, is one of the complications of ACS. It's a cold and wet state due to end organ hypoperfusion, cold extremities, and pulmonary edema. In terms of diagnosis, there's an SBP or systolic blood pressure lower than 90 or mean arterial pressure 30 below the baseline, a cardiac index less than 2.2, and a pulmonary capillary wedge pressure over 15. Causes are often due to acute MIs, especially ones that have a delayed reperfusion therapy or are not reperfused. And they're associated with these complications we talked about, like papillary muscle rupture, cardiac arrest, arrhythmias. It can also be secondary to an iatrogenic cause like cardiopulmonary bypass. Management is with, or evaluation is with ECG, chest X-ray, lab work, either TTE or transesophageal echo, and a lung ultrasound. And it can also be beneficial to use invasive monitoring, like an arterial catheter for BP monitoring, transpulmonary thermodilution to measure the cardiac index, and then a pulmonary artery catheter to monitor the wedge pressure. In terms of treatment, it's important to address the underlying etiology, such as with coronary artery revascularization or surgical intervention for a severe valvular pathology. Prior to definitive treatment, the patient's hemodynamics can be managed by reducing afterload, improving tissue perfusion by raising the blood pressure, and norepinephrine is the first-line vasopressor of choice, or supporting cardiac contractility with inotropes such as milrinone and dibutramine. These patients often have significant pulmonary edema, so they will likely need some form of mechanical ventilation, and then they have acidosis from the lack of tissue perfusion and may need renal replacement therapy. For patients who do not get better from addressing the underlying etiology or just with support, they can get what we call mechanical circulatory support, such as an intra-aortic balloon pump or extracorporeal membrane oxygenation. Those are definitely beyond the scope of this talk, but we have another QR code to the ICU one-pagers websites, which provides concise overviews of these managements. And these mechanical circulatory support can be a bridge to a more definitive intervention or to a heart transplant. Finally, we just want to provide a resource for advanced cardiac life support, ACLS, which may be necessary for patients who go into cardiac arrest from pulseless ventricular tachycardia, ventricular fibrillation. These are, again, those electric complications of MI, as well as asystole and pulseless electrical activity. You can find these algorithms in the QR code. And there are two broad categories: rhythms that are shockable with a defibrillator, which would be ventricular fibrillation and pulseless ventricular tachycardia, and then rhythms that are not shockable, which is asystole and pulseless electrical activity.
So in summary, this is just our take-home message for today. So remember, a patient coming in with acute coronary syndrome is actually whatever interventions you're going to give to this patient is actually very time sensitive. So once you have a patient, as you've gone through a patient who you are highly suspecting, you have a high index of suspicion of an acute coronary syndrome. So in whichever facility you are in, remember aspirin is actually, it has a mortality benefit, and it's actually quite easily accessible to all of us. So if you're able to administer it, as long as you rule out any contraindications, as you see anything such as aortic dissection, please administer aspirin to the patient. Give oxygen if the patient is in respiratory distress and is desaturating. You can do your ECG if you're in a facility where you're able to do one. Then, depending on your ability to do whatever procedures or whatever interventions you can do, you might have to refer this patient to a center where they're able to offer PCI or any other additional interventions they can do. So keep in mind that most of our interventions here are quite time sensitive. Remember, you have to visualize the patient or thrombolize the patient within 30 minutes. So the door to needle time is actually 30 minutes, and the door to PCI time should be anything 90 minutes, should be up to 90 minutes basically. So remember, even the duration of symptom onset from the point of first medical contact also matters here quite a bit. So remember, when you're giving morphine also for pain control, when you're using morphine for pain control, remember it's only indicated for patients who are quite in a bit of pain and discomfort, and patients who have not responded to an nitroglycerin. So give it cautiously. Sometimes it can worsen your hypotension in patients who are hemodynamically stable. So thank you for listening.
These are the resources that we mentioned, including an infographic on ACS and some of the other ones that have been linked to QR codes earlier in the presentation. So thank you so much.
We have one question, if we have an extra minute. Is the benefit of aspirin dose dependent? Also, for how long are you giving high dose aspirin?
That's at least in terms of the dose, from what I've read, there hasn't been a significant difference between 162 milligrams and 325, though we do typically give 325. There is a somewhat higher bleeding risk with the 325 dose, but I don't think it's super significant. Patients who have ACS should be continued on aspirin indefinitely, but it would be at a lower dose.
Thank you so much.
Typically you just aspirin load them the one time, and then as Dr. Liu was saying, then we progress with a 81 milligram baby dose aspirin from there on, just for like modification and medical management and prevention of further cardiac events.
Additionally, we have a new question for clopidogrel dosing as well. So that is the same, where you would have a loading dose and a 75 daily. I believe the loading dose is 300 milligrams and then 75 daily. Unfortunately, management of ACS in the gravid patient is beyond this discussion, but that is a great question for future webinars.
Thank you so much I think for the sake of time, we will reserve the rest of the questions in the chat to our Q&A document that will be posted to the Learning Resource Center in the next coming days, as well as all of the material that you saw today, including this lecture and the recording. We appreciate you all joining us for the last week and participating in all of the topics that we have given you lectures on. It's very much appreciated from us, and I know our presenters appreciate your participation as well. The certificates, which I know we have a lot of questions about, will be given out within the next 7 to 10 days. So if you don't receive anything today or the next day, please do not panic. We will try to get you all the certificates as in a timely manner, and they will be given to the email that you have provided based on your registration. And please continue to use all the resources that we've provided. They are for you, and we are happy to help in any way that we can. My final announcement is that this is the last of the series for this week, but we will continue this in a similar fashion on a much less concentrated scale. So we will be doing one session per month that will start either at the end of September or beginning of October. So be on the lookout for that as far as marketing and continued registration to get included in those lectures as well. And we will continue to pick topics that are high yield to you all. And we love the feedback. So thank you, thank you, thank you. We very much appreciate you all. And it's been remarkable, the turnout that we've seen the last 5 days. So we appreciate it.